Okay, good afternoon, everybody. And it's been an interesting day or afternoon. Thanks again. And Lucas just told me his flight is leaving at 9 o'clock, so we will speed up a little bit.
No more questions.
And so without further notice, I'd like to ask Jens Erik, you have 10 minutes for the presentation of the option trial results.
Can you put the slides on? Yeah, okay. So you all know that this trial was published and presented at the American Heart Association with a co-publishing in New England Journal of Medicine in November. And I will go very fast through this because you all know about this. But the real purpose of this study was to investigate if mechanical stroke prevention by left atrial appendage closure with Watchman Flex after ablation or at the same time of ablation could be associated with a lower risk of long-term bleeding than anticoagulation DOAC while maintaining effective stroke prevention. That was the purpose. And patients were, of course, in AF, they were all suitable for ablation. They had to have a certain risk of stroke, CHA2DS 2 or more men, 3 or more women, 1-to-1 randomization, 1,600 patients, follow up for 3 years. And the closure procedure could be either done at the same time as the ablation or it could be sequential 3 to 6 months after ablation. And post-procedural medication, LAAC had DOAC plus aspirin for 3 months, and then aspirin up to 12 months, and the control group had their usual, the majority of patients, the DOAC treatment. And the primary safety endpoint was looking at major bleeding, non-procedural bleeding, and clinical significant non-major bleeding in a superiority testing. And of course, we looked at efficacy related to stroke occurrence, systemic embolism, all-cause death. And then a secondary safety endpoint was looking only at major bleeding, including the procedural bleeds. The bleeding classification that was used in this trial was the ISTH, major bleeding, which is really a hard criteria, fatal bleeding, critical organs, heavy fall in hemoglobin. And then we had this clinical relevant non-major bleeding, which is also really significant bleeding, meaning that patients having this type of bleeding, they did seek health consultations or even treatment or even in sometimes hospitalization. So this is really also clinical significant bleeds. So if you look at the patient characteristics, typical of probably of a ablation population, but yeah, maybe higher risk. Actually, the CHA2DS was 3.5, Hasbled quite low, 1.2. And you can see that majority, or there was about the same concomitant, 40%, sequential 60%. This was before pulse field ablation, so both cryo and radiofrequency. And let's go and look at the results right now. The device group, looking at the primary safety endpoint, there was 8.5% of bleeds in the device group, and in the anticoagulation group, 18.1%. This was non-procedural bleeding, both major and clinical non-major significant bleeding. Efficacy with a combined endpoint, including also stroke and mortality, was 5.3 versus 5.8%, and major bleeding events 3.9 versus 5.0. So numerically also less bleeding with in the device group, and the primary safety endpoint highly statistical significant with less non-procedure related bleeding. So this is the event curves where you see a clear separation between the device group and the anticoagulation group, telling that the bleeding risk is lower when you get the device instead of the anticoagulation strategy. And this has been criticized a little bit because it's it is bleeding that are not related to the procedure that is not included, but those curves here, that is actually also including all the procedural bleeds, and even if you include all the procedural bleeds, there's a very clear separation here between the device group and the ablation plus OAC alone group, 18.1% versus 9.5%. Efficacy, you see the same efficacy in both groups, and very importantly, the most interesting parameter here is ischemic stroke. Very low ischemic stroke rates in both the device group, 1.2% and 1.3% in the all anticoagulation group. So you get the same degree of ischemic stroke protection from the device than compared to DOAC. Almost every patient were in DOAC, very few in VKA. And major bleeding, non-inferior between the two groups, but also again numerically with a tendency to less major bleeding for the device group compared to the oral anticoagulation group. Subgroups, a consistent results with all the subgroups here. And we have already seen this figure here that it is, you can see that we had 85% adherence to DOAC treatment over the trial period, and very few patients in the ablation group did take oral anticoagulation. So also it was noteworthy to see the complication rate. We have already seen a little bit about this. Procedure complications totally in the ablation plus device group, 2.8%, 0.6% related to the device. Pericardial effusions very low in both groups. Very good results, also a high sealing rate and a quite low device-related thrombosis rate. So what about, is it better to do concomitant or is it better to do sequential LAAC? This is not part of the publication, it's a sub-analysis, but you can see that it appears that it's exactly the same signal whether you go for concomitant procedure. You have more bleeding in the OAC group with Bro's concept, and you also have equivalent primary efficacy, whatever you go for concomitant or sequential procedure. So in my mind, we can conclude that catheter ablation combined with left atrial appendage closure by Watchman Flex in AF patients with an increased stroke rate reduces the long-term risk of bleeding compared with DOAC while maintaining effective stroke prevention. And I think we can conclude that the combined ablation and LAAC using Watchman Flex is safe and actually superior to DOAC post-ablation in AF patients at increased risk of stroke. So this was a little bit rushy, but we need to have more time for discussion. So thank you.
Well, that was really a rush. I think this study is a milestone that we have waited for really for a long time. However, in the general non-LAA club colleague round, there has been a lot of criticism. So my first question would be to the audience: has anybody open questions to these data? let me pick one point. Somebody noticed that in one of the slides, concomitant was said to be within 10 days, and that raised some questions. I wasn't aware of that, but these 10 days are between randomization and a concomitant procedure. It was not AF ablation and then 10 days to the LAAC. Huh? So that can be clarified. Any other questions?
Yes, I have one question about the endpoints. There's the death as an endpoint, and we know that the LAA closure doesn't reduce the death, neither does the DOAC. So why is it included? I think it increases noise there. And then the second question, the amount of strokes are very low in both groups as anticipated. So could you, is the conclusion right because of those small amounts? Should you have a larger amount of patients or longer follow-up?
No, you're right. Is this working?
Yes, it is.
Okay. You're right about including deaths, but you're not right that this is not a signal that we have seen before, because if you look at the Protect AF Prevail and also the PRAC 17, if you look at this analysis, there's a clear trend that the mortality actually is reduced, and we know that major bleeding can increase mortality for AF patients. So I think it's very fair to include death in the efficacy endpoint. But I think the most interesting in the efficacy endpoint is to look at the ischemic stroke rate, which was similar. So that is, but the argument that death was included is that you can actually see a signal in our previous LAAC trials that cardiovascular mortality and all-cause mortality is reduced.
I would add that death is important, because if a therapy reduces stroke but then you die by the therapy, that is a relevant endpoint that you should include in that combined endpoint. Luckily, that's not the case.
I think we will have a lot of more discussion over this whole thing, but maybe we spare some time and already move on to the next talk from Claudio Tondo. And the first talk you give is on radio frequency, cryo, or pulse field ablation energy. Does it matter for LAA closure?
Good afternoon. Thank you, Martin. I think that I'm a good track after Erik, presentation of the option trial. So I think that we have a robust data already in the literature out there that concomitant AF ablation and LAA closure can be done, and it is feasible and safe. Lucas has been one of the pioneers in this field by using RF. In our group, actually we use cryo for treating patients with the main circumstances, paroxysmal atrial fibrillation, in preventing stroke and reducing, obviously, the major bleeding. The slide shows that regardless the energy source that you use, radiofrequency or cryo balloon, and these were the first data that were published, the calculated stroke risk based on chest vascular versus observed stroke rate with radiofrequency was significantly reduced, as well as the bleeding risk based on ASBLAT versus the observed bleeding rate. On the right hand, we have almost the same data using cryo, because the aim was just to reach the isolation of pulmonary vein, which is the cornerstone of catheter ablation and atrial fibrillation, with a significant reduction in the bleeding rate and the stroke rate. But as you know, we have a new energy source in our field, which is considered the real revolution. And therefore, we are just, ready just to explore whether or not pulse field ablation in the single combined procedure can be done and obviously can be maybe superior to the previous energy sources such as radiofrequency and cryo. We have some hypotheses. Number one, the PFA devices allow one-shot PVI as compared to RF, and reducing probably the procedural time compared to RF. Number two, PFA probably has the potential to reduce the major complication during catheter ablation related to the fact that is very specific to the myocardial tissue. And this is probably really critical if we consider that most of the time we close up the appendage in patient older and frail who often have indication for the concomitant procedure. Number three, PFA devices do not depend on vein occlusion, unlike cryo, for example, and the single transeptal puncture can be performed in a more suitable position for the appendage access. And four, also we need to emphasize that there's a non-thermal energy source, and PFA may create, there's an hypothesis, less edema in the left superior pulmonary vein ridge, reducing the risk of peri-device leak. Now, we don't have a robust data in comparison and the literature among the different techniques. But let's go into details. This is one of the first publication concerning more than 1,500 paroxysmal AF patients undergoing pulmonary vein isolation in 4 institutions, and they provide a comparison in 1:2 fashion in a propensity score across pulse-field ablation, cryo, and radiofrequency. In terms of success rate for AF ablation, there's no major difference in between the 3 energy sources. But if you look at the procedural time, the major complication and minor complication, actually the use of PFA appears much more favorable in regard to procedural time as compared to cryo and obviously the RF. This is a recent publication from our group concerning the potential advantages using PFA in the single combined procedure, especially in elderly patients. But PFA in these circumstances is proved to be safe in both paroxysmal and persistent AF patients, regardless of age, with an overall low rate of complications. So it looks like that probably we have much more liberty to use the PFA than the other energy sources, especially in treating patients in elderly circumstances. Like in this presentation, also we have the device that, as I stated before, do not depend on the vein occlusion, that the single transeptal puncture can be done probably easier and just to reach out the appendage and close up the appendage. The combined procedure, this is a study in which the patient were randomized between PFA and plus the appendage closure, or the PFA only, just in case they were considered unsuitable for the appendage anatomy. As you can easily appreciate, the procedure time around 80 minutes. The appendage closure took less than 20 minutes, 100% the acute success rate, and no major events were observed. Obviously, if you consider some parameters in the retrospective comparison, considering the total procedure time, we don't have main difference between the combined procedure and the AF ablation only. Obviously, if you consider other modality of ablation, like ablation with or without the 3D electroanatomic mapping, you might have differences in the procedural time and the fluoroscopy time. So already we have mentioned the issue concerning the edema that you can promote. even though there's no robust data that substantiate this statement. But less edema, probably in the left superior pulmonary vein ridge, reducing the risk of obviously the dislodgement or even, just the non-perfect occlusion of the appendage, and then you have a leak. So the primary indication for left atrial appendage in the pulse field ablation cohort was the electrical isolation during extended ablation that was done almost in 48% of patients, whereas in the RF cohort, in the paper that I just mentioned, the most common indication was a history of major bleeding in almost 57% of patients. The procedural time was significantly longer for RF cases, although RF cases require less fluoroscopy time than the PFA, especially because PFA in a paroxysmal atrial fibrillation is not always used with the 3D mapping. The overall leak rate was significantly higher in the radiofrequency group compared to the PF group. However, if you consider the leaks more than 5 millimeters, the difference lost significance when analyzing this issue. The rate of stroke was 4.5% in RF versus 0% in PFA, and major bleeding was almost 7% in RF versus 0%, but during the follow-up, this was not significantly different, but it was just a trend between the two groups. In conclusion, if we consider the comparative studies evaluating the PFA plus appendage closure versus RF and appendage closure versus cryoballoon and appendage closure are currently lacking, limiting direct assessment of the relative efficacy and safety. However, the pulse field ablation has the potential to overcome traditional challenges associated with other AF ablation techniques combined with appendage closure, such as procedural efficiency, energy-related complication, and post-procedural leaks. If you don't mind, I can, jump in the, following presentation because there are, some overlapping issues. I think that we can just discuss later.
I think if we just have two questions,
okay,
because I think it's an issue. Lucas, I remember your group, based on the reimbursement that you get in the Netherlands, published already on concomitant procedures like 10 years ago, so it at least feels to me. I think we should hear you on this topic here. You should have experience in the sizing, which now is an issue because of the edema that we create. So what's your take on this?
Yeah, thank you. Indeed, it's true that we did this in our own center, and we were one of the first to start with that. At that time, all these things about sizing and things like that were not so well known, and also edema and things like that, and the combination with ablation and appendage closure was not that well known. And everybody has leaks small leaks after appendage closure, so we didn't bother too much about that. Actually, when we look at the paper that we did after the evolution trial, we did see that although the acute closure rate seemed to be equal, let's say, depending on whether you did appendage closure alone or appendage closure after RF ablation, you did see that the small leaks actually were a little bit bigger in patients that had a combined procedure with ablation. And that was published, I think Karen Phillips was the first author of that, and that was from the WASP and Evolution registries that we combined these patients that had a combined procedure. And there you indeed saw that there was some trend to some more leakage, small leakage, not large, but small leakage in the patients that had a combined procedure indeed. And I think Claudio makes a point there that with PFA you may expect not to have that edema, but I think that we need much more data before we can say that. And well, maybe we can learn that as a sub-analysis of the option trial. I think it's one of the, I'm not sure if it's one of the pre-specified sub-analysis, but I'm sure there will be a sub-analysis of that for sure.
Yes, I can add that we are also very enthusiastic about the concomitant procedure because patients will like it. But my colleague Christian Heger has been very active in the PFA field, also with several devices. And it doesn't seem to be this black and white. So we also saw some edema even with the PFA, although it's that appealing. So we should all take care not to ruin the therapy by just ignoring that factor.
Yeah, I think that if you go to PFA, already there are some publication concerning the interference that you might promote if you already have, for example, the appendage close with the device. So the suggestion is just let's do the ablation first and then close up the appendage. If you consider just to have a concomitant, just another story if you do the sequential. But just because the electrical field that you create might produce some interference with the device.
It's interesting. There's a publication from Pavlos Manchik, and he's looked at things like inflammation and destruction of tissue. And you actually see that with PFA, if you compare a PFA to an RF procedure, that you do see a lot more damage. You see troponin rising a lot higher with PFA. So probably the acute effect of electroporation is pretty heavy also in that ridge between the appendage and the left superior vein. So it would not be, I would not count too heavily when you make holes in cells that you will not get edema.
Yeah. It's a long way to go, I mean. Yes, let's move. Okay, so I think the concept is there. I mean, just left atrial appendage closure combined with ablation, concomitant or sequential. I think that you have already seen this slide before. This was actually one of the publications almost 10 years ago, and already you have the sense which patients can benefit from left atrial appendage closure, even patient unwilling to continue or unwilling just to or unable to take oral anticoagulation. At the right end, there is a list of the medical condition which represent contraindication to long-term oral anticoagulation. We can just skip. I think this really, I like this slide because I've stolen from John Camp. This was one of the review, and this was one of the comment that I made before. Because obviously we have a continuous struggling between the writers of the guidelines, which I consider, sometimes like, behind what the operators and the experts in the field are doing, pushing, just because the technology advancement, and try just to propose a new modality of approach, especially in patients with atrial fibrillation and major bleeding or anyway with a high stroke risk. And this is probably one of the reasons because we have quite a strained relationship between the society guidelines and the guidance proposed by experts in the field, which is probably one of the reasons why we're still struggling with the international guidelines. So why concomitant plus catheter ablation? I think that one of the reasons is, yes, I mean, the patient is much more compliant if you propose to have a catheter ablation, atrial fibrillation, and you might propose the catheter ablation either for paroxysmal or persistent atrial fibrillation. You need just to do one time the transseptal puncture, and please note that there are still complications related to the transseptal, so I think that we need just to take into consideration even the puncture of the septum as a complication. And obviously with the option trial, probably we have paved a new avenue for treating patients with atrial fibrillation, and they can benefit from appendage closure as well. Obviously, we need to take into account, at least in Europe, for the economic constraint that we still have. Well, if we consider what data we have in the literature, this is really a very recent publication. There's a meta-analysis, 8 studies comprising more than 50,000 patients, from whom 2.6% underwent combined catheter ablation and appendage closure. And this meta-analysis or observational studies, as you can easily appreciate on the right end of the slide, combined appendage closure and catheter ablation for AF was similar to isolated appendage closure in terms of efficacy and safety. So we have a strong data in the literature. Just to be practical, I want to just submit this clinical case that's really a demonstration how to is possible to treat patients. This was a female, 60 years old, suffering from hypertension, and the first diagnosis was symptomatic atrial fibrillation in 2021. As usual, she had the very beginning cardioversion, and then early recurrence, despite anti-arrhythmic drugs, is usually the only story that we usually observe in many patients. In 2022, she suffered from spontaneous intracranial hemorrhage that was managed conservatively at that time, and the following year she was referred to our center, and then we decided just to propose the combined ablation and appendage closure. The pre-interventional imaging, as usual, TE, we like just to have TE, but the CT as well, just to prepare for the ablation, and then the closure of the devices was just the imaging. The patient actually was in persistent atrial fibrillation, so I just put up this slide just to show you, especially for those who are not in the field of electrophysiology, how to treat patients with a persistent atrial fibrillation using pulse field ablation. One of the concept is obviously pulmonary vein isolation, still the cornerstone of ablation of atrial fibrillation, but usually, at least in our center, we like to jump out of the pulmonary veins and isolate as much as we can the posterior wall of the left atrium, which has the same embryological origin than the pulmonary vein. So this is a very specific and critical area just to reduce the probability to have recurrences of atrial fibrillation. And at the bottom of the slide, you have the maneuvering of the catheter and the PFA. This is just a further pulse catheter in the flower configuration that allows you to promote the isolation of the pulmonary veins. And this is just how to move the catheter just to eliminate all the electrical activity and a posterior wall, just an example. So once you have, you are done with a catheter ablation, what we do just to introduce the ice in the left atrium. We usually use ice to close up the appendage, or in almost all patients. And we position the ice in the left atrium, and then the Farah drive sheet was used to perform the angiography, and then we exchange the Farah drive sheet. Was replaced, in this case, we use a Watchman device with a 14 French dedicated sheet. Device sizing by using the pre-procedural imaging, comparing what we get from the angiography and from the eyes as well. And then there's just the angiography. And it takes just less than 30 minutes just to close up the appendage. After catheter ablation, the total time of the procedure was 80 minutes, so you can appreciate how fast could be the ablation at the beginning, and then the closer, and you put the device. So this is just an example how to use the combination of the two procedures. The patient was discharged from the hospital, everything was great, and therefore this was just an example. 3 months later, the patient was already studied with TE, proper appendage device position, no evidence of peri-device leakage, and this was really a good example of a combined procedure. In conclusion, the combined AF ablation plus the appendage closure may offer significant advantages compared to sequential, at least in our view, as it has now increased procedural risk while minimizing patient discomfort and reducing waiting lists. Just please take in consideration we don't use the TE during the procedure, so we don't need to have the anesthesiology in the operating room, but just, mild sedation, and this is very useful, and obviously the compliance of the patient is very high. The optimal drug therapy combined after the combined procedure remains unknown, and largely depends on the indication for appendage closure, prolonged anticoagulation if closure follows electrical isolation of the appendage, or shorter if closure is performed due to major bleeding or a high ASBLED score. The combined procedure does not seem to increase the DRT, and obviously this is probably the Achilles heel, that is the reimbursement that should be available in the UE, as in the US, to enable physicians to perform this procedure without institutional constraint. And I will stop here. Thank you for your time.
Thank you, Claudio. I think you've already shown that in the US, people are already sort of advancing on these data that we have from option, and there's now even a DRG where you can do a combined concomitant procedure. So we are actually lagging and not leaping here in Europe, but the leap is actually going on in the US. What do you think? We haven't seen the sub-analysis of the option trial looking at the concomitant against the sequential procedures, but what would your expectation be?
Well, I'm in favor for the combined, so and I will keep going, even though just still the reimbursement. Probably I'm quite lucky because the hospital allows me to do it, but I guess that probably if in Europe we're going to adopt the option trial result, probably the majority of operators and EPs obviously probably will do just the sequential and not for the concomitant. For the time being.
I thought it quite intriguing. I think Jens-Erik showed the subgroup analysis of concomitant versus sequential because they were presented at one EP meeting in the US.
Yeah, but against OAC and not compared to each other.
Right.
But anyway, I think we will come back to this topic when we do our last part of the discussion, and we will talk a little bit more about sequential or combined procedures. So it's my pleasure now to introduce you, Martin. You're going to talk about who the patients are that actually would benefit from a combined ablation and appendage closure, either concomitant or sequential, probably.
Well, I don't know whether this is the right presentation because we had let's go on. Okay, I will pick up a few slides from the option trial because from that on we can decide whom we're going to treat with this approach. And I'm really thrilled with the option results because if you consider clinical trials at the highest level, you want to publish them in the New England Journal of Medicine. And we should be aware of that option is actually only the second trial that makes it to the New England of this whole field. That's why I summarized all the New England publications that you find if you go for LAA. The only other one is actually LAAC, something we are not very keen on from an interventional side. And then you go back to 2009 on the lower right, and that's all you find about LAAC on the level of the New England Journal, aside from option. So Jens-Erik did a good job already to summarize. I also prepared a slide here, and we should see that 59% of the patients in the option trial were on what I would say the state-of-the-art NOAC, so that was apixaban. The mean CHED-SWASC was 3.5. HASBLED was very low, only 1.2. And both concomitant within 10 days of the randomization as well as sequential. From an IC standpoint, actually the sequential 90 to 180 days is much more interesting than the concomitant was studied, and we now have the data. So at 3 years, that we shouldn't forget, so that's really a long time, we see this very low rate of stroke and systemic embolism and clinically relevant bleeding, which I would summarize as those bleeding events that usually stop patients from taking NOACs, or at least pausing them, was really massively influenced in favor of LAA closure. This was a study protocol again. This was already shown. Again, we are talking about 803 ITT patients versus 797 ITT on the ablation plus OAC population. 3.5 has bled and sequential 60%. I would stress the point here that all of this is intention to treat, and I'm going to show you the numbers in a minute, that we had a number of crossovers. This was a US trial where LAAC is very common and very favorable. So actually part of the NOAC group were patients that were switched over to LAAC. Primary efficacy, and the subgroups, and that might maybe to the question regarding mortality. Indeed, we had not significant, but if anything, positive signal towards the LAAC group, 3.8% mortality due to a lower event rate in the non-cardiovascular group, obviously something we can't explain here at the moment, versus 4.5% mortality in this elderly population when you take the patients on OAC. Systemic embolism very low, and ischemic stroke in favor of what we see. I thought this would be a new slide, but you already showed that again. Many people always questioned this non-procedural bleeding rate and ask, okay, where are the procedural bleeding rates, and will they increase and somehow change the endpoints that we said? That's why I think this slide is really important, where we have the major bleeding, including the procedural events, that was presented at the AF symposium in the US, and you see that still the results are very much in favor of the left atrial appendage closure. And this is 18.1 versus 9.5% at 3 years, and the groups diverge already very early on at 90 days once that is shown. Now, let's have a short look. I think this is something you also showed already, but maybe we can repeat and take a little bit more time. That was the on-treatment analysis. Here we still see a large benefit regarding the bleeding events in favor of the LAAC group, and all the other endpoints, including primary efficacy and secondary endpoints, is in favor of the LAAC. So the title of my talk was obviously, so who are the patients that we should go for combined ablation and LAAC? Let me take this based on these data. We've seen the guidelines, which are now at the current standard have a 2B level C recommendation, and you picked on that correctly, and hopefully we will see an update. So what is the patient that we can offer now the LAAC? Well, all patients that received AF ablation for their rhythm control are now potential candidates for LAA closure. And if the current guideline recommendations are something that is really influenced by the data, then I would think with this one randomized trial that we have of the moment, we would expect this to be raised to a 2A, level of evidence B, because we have one randomized trial, not yet two, or say, 4, and that has been the same in the rhythm control guidelines that were published 4 years ago, where suddenly Lucas, as an EP background, I think you will remember those times that it's not anymore one is superior to the other, but patient choice is now something that's coming into play. And I would argue in favor of that. We currently, with these option data, can offer our patients, let be the reimbursement side away, that every AF ablated candidate is somebody who should be able to choose between NOAC and AF ablation 90 to 180 days after the AF ablation, or maybe even concomitant, but that's another issue where reimbursement really comes into play. And this is something that I would take for discussion.
Thank you, Martin. I think that's one of the topics that you are going to discuss. Is there anyone that has a burning question about this yet? Or maybe we can also take that into the discussion, because we have some provocative questions for the panel, but also for you to see how you think about that. Any? Yeah.
For the electrophysiologist, how often do you have to do like a redo ablation if there is a recurrence of the AF? And then if you have the device in place that you cannot ablate the appendage?
Well, I thought it very interesting that in option, 75% of the patients were in sinus rhythm at 3 years, and the other 25 were either unknown or had a recurrence rate. 6% had a redo ablation, if I recall correctly. So, I mean, that's what we know from everyday practice. The success rate of ablation is not 100%, particularly in patients with CHED-SPAS of 3.5. I mean, these are also persistent AFib patients. And as far as I understand from the EP field, we have a very active EP program also at my department. Some of EP people like also to ablate the LAA, because it might be a focus of recurrence of atrial fibrillation. All this would argue still, I guess that's what you're turning to, in favor of sequential ablation, because then you still can ablate the LAA. Don't know, Lucas, your opinion on that?
Yeah, I think in general the redo rate is about 10%, but it depends a little bit on paroxysmal or persistent patients, because there the redo rate is usually a little bit higher because the recurrence rate is higher. I'm going to show some data on that in my last talk, but maybe Claudio, you can.
No, I completely agree. I want to just touch just one issue concerning the difference between a paroxysmal and persistent. I mean, just obviously, I'm not in favor just to close up the appendage in every patient with paroxysmal atrial fibrillation, especially in young patients where hopefully the recurrence rate is much lower. But I would consider, obviously, also based upon the option trial result, that persistent AFib patients should be primarily considered for the combined procedure, because they are at a higher risk to have recurrences during the follow-up. So those is the category of patients that I would focus on the combination of the two procedures. So I think this is it's critical just to distinguish the two different clinical presentation of atrial fibrillation.
Thank you. I think we should move on to your second talk, which is on who and how should the combined procedures be done, and can the results of this trial, the option trial with the Watchman, can it be extrapolated to other appendage closure devices?
Yeah, thank you. So I put up a few questions that I will try to answer in the talk. I think one burning question that we already touched on is the issue of pulmonary vein isolation causes edema, and then we have a question of sizing and leakage. Obviously, it's quite attractive for the patient and might also confer a safety benefit if we only do one transeptal puncture, arguing in favor of a concomitant procedure. However, if the LAA might be a source of the AFib stimulation, then we would think of isolating that. And so far, the subgroup analysis is coming up. So what are the techniques of PVI in 2025? This was already summarized by you. We have cryoballoon, we have radio frequency, and now we have the pulse field ablation, which is particularly attractive. And you didn't touch too much on that, but I can observe it every day because the procedure is so much faster. So now you can do it, can do 4 procedures a day if you just go for single-shot devices. I won't talk too much about the energy form. However, if we talk about different devices, we need to think about what are we going to do with the pulmonary ridge, and do we need to work on the pulmonary ridge from an EP side. And with the CT planning, which particularly in these patients, I guess even as a German, and you know we're very reluctant to move towards CT, but I'm reaching out my hand to the northern colleagues that I'm convinced that in particular in concomitant procedures, we cannot do anything without the thorough CT planning, because we will be misled by the measurements that we do within the procedure. If you compare single lobe devices to two-lobe devices, these are 3D pictures. You immediately realize that it might be a good idea to leave the ridge free. However, if you look into the literature, there has been a presentation that I would like to share with you, also with the 2-disc devices. If you look at these CD pictures from Ole de Bacter with the FEOPS modeling, however, you see you might have an issue with the ridge and what you do there. However, out of the EMERGE post-approval study, there are these data. It's a comparison of a patient that received just LAA closure with those patients that were entered into this prospective registry that concomitantly received ablation. We compare here 182 patients compared to the Amulet alone. That was close to 12,000 patients. This is a retrospective analysis, and we can only look at implant success, device closure, stroke, major bleeding. One missing issue is whether the patient stayed in sinus rhythm or had a recurrence of AFib. Age in the concomitant procedure was a mean age of 74. The pure LAA occlusion group was a little bit older. All the other parameters were more or less similar, with a population that got the concomitant procedure to be a little bit healthier and a little bit longer. There are no differences regarding in this registry. Obviously, the patient choice might be biased, but if you apparently have a rationale to do this, then you can do both procedures also with a 2-disc device in one procedure. Procedure time is a little bit longer, 85 minutes versus 106, although we don't know what kind of AF ablation was used. The post-procedural therapy was similar between the two groups. However, the LAO plus catheter ablation obviously received more OAC. I guess this is because of the thought that we create a scar with the ablation, and that's where we need 3 months of anticoagulation, so not to get a clot from the scar that was formed by the ablation. If anything, endpoints were less safety endpoints for the ones that got the concomitant procedure, but this I would say would mirror that these patients were healthier, were younger, had a lower CHEDS-VESC. However, there's no sign of any increased risk of doing that with this in a retrospective analysis. Same is true for leakage. However, I couldn't find in the presentation whether all these patients received CT or TOE, or what was the follow-up. However, obviously, apparently, those patients that were looked at had a high success rate in complete closure. So how should it be done, and how should the devices be used? I think how should it be done? The most important point is that if we do a concomitant procedure, we're talking about a thorough pre-procedural imaging, where the CT, in my view, should be the gold standard and decide about the sizing. Single-disc devices obviously show less interference with the pulmonary ridge. We only have prospective data now regarding the Watchman Flex. Retrospective data, though, also suggest feasibility of this with other devices. I guess we should force everybody to do prospective studies on this because it's the most important point. Reimbursement is critical for adoption of the concomitant procedure. I would like to stress that at the moment, also for time reasons, our EP labs, at least in Germany, are usually pretty booked. Waiting time locally in Hamburg, even though we have 4 big centers, is now up to July. So just for practical reasons, I would think we will end up more looking at the sequential procedures, which might also be, from a quality standpoint, the one that we should go for. We have the time for planning the procedure. We might get away with the edema. Option is here really a huge step forward. And I come to the same conclusion as I did before. I think we are already in the time where we can have a patient choice, whether we go on with DOAC or we go on with LAAC in AFib patients that received ablation. Thank you very much.
Yeah, thank you, Martin. I think you touched on some important topics. Maybe we should immediately go into the discussion, because I think that some of the topics that you and Claudio have mentioned, I have put some questions around these, and to enter into the discussion, it's obviously good to get some provocative questions here. So maybe I should stand there and then I'll give the podium. Let's see if that works.
I see everybody nodding, but there has been not enough activity, I think.
Well,
so now you guys need to raise your hands. Huh?
Yeah, I hope so. If my presentation comes up, so far it doesn't.
Sorry, there's the first question.
One thing regarding all this thing of treating younger patients with healthier atriums, the thing is that we may need a long follow-up of these patients just to know the results, because the thing is that most of these patients will be in sinus rhythm. So in sinus rhythms, it's not so important, for example, a proximal implantation or the device or how the device is implanted, because the flow of the atrium just wash everything and it's less possible that you have a device-related thrombosis. But we don't know, maybe after several years, if they enlarge more the atrium or they get permanent AF, how this maybe suboptimal, I don't know, treatment of the appendage, because again, maybe these patients have more difficult appendage to close. We don't know in the mid or long term how it will end. I don't know, what do you think about that?
And is 3 years enough for you, which we have with the option, or do you ask for more years?
Well, it depends of the age of the patients, because if you are closing appendages in patients that are maybe 50 or 60 years old and they are quite healthy, maybe you need to look longer than that.
But these patients, I think, were in the mid-70s. So.
Yeah, mid-70s, maybe 3 years, but not only with endpoints, with an imaging techniques to see how is this thing. Because most of the problem with all the studies that compare things is that sometimes the second follow-up imaging is not performed in most of the patients, because most of the studies, the follow-up second imaging is around 30%. So we are very happy with the first control, but the patient is with all the treatment, and then we don't know what is happening with them. So maybe at 3 years, if they have a proper follow-up imaging, it will be something. At least it's more than we know for sure.
I would probably say that if they have endpoints, that there will be some more imaging and things like that. So if there are endpoints related to stroke or bleeding and things like that.
No, that will be very interesting. But I think that at least in this course, that our study course, will be interesting to know more, because it's like a new landscape that for the moment we are not treating so healthy patients, and we need to know more than only the endpoints. I think it's interesting how these appendages during the follow-up are evolving.
Yeah, I see what you mean. There's some long-term follow-ups, but it's usually clinical follow-ups, even lasting up to 10 years. And we have option of, we have the older trials with against vitamin K, where we have 5-year follow-up. But usually imaging is not part of the 5-year follow-up of all these studies.
But maybe an idea is to get a small cohort of these big studies and just make a follow-up imaging, but in the long run.
I see what you mean. Yeah.
So to start some of the discussion here, so I was asked to give a presentation, but I actually thought it would be much more interesting to discuss this and also hear from you what you think about these data from the option trial. So these are my disclosures. So you've seen the data from option, but I wanted to go back a few years back to Cabana, and most of you are not electrophysiologists and probably have not heard of Cabana, but Cabana was a very important trial doing ablation versus antiarrhythmic drugs in patients with persistent or paroxysmal atrial fibrillation. These are also patients that are 68 years of age, higher BMI, half was persistent, half paroxysmal. And many of them had failed a first antiarrhythmic drug, and then you saw that catheter ablation was actually doing better than antiarrhythmic drugs. But still, if you look at AF recurrence, and there was a question here, AF recurrence, if you look long enough, is at least 50%, and probably if you look very intensively with loop recorders and things like that, might even be more. But that doesn't mean that it's not feasible to do it. Not all these patients get a redo, because that was obviously your question, how many get a redo? That's usually less than that 50%. That's usually more in the area of 10%. And interestingly, these were patients that had a mean CHA2DS2-VASc score of 3. Option was a little bit higher, 3.8, 3.9. And the disabling stroke rate in these patients was very, very, very low. So the really severe strokes were very, very low on anticoagulation. But this is something that we have to keep in mind when we think about stroke reduction. How serious are these strokes? And the other thing was major bleeding was about 3 at 4 years. So the 4-year rate was 3. So also that is for major bleeding, not even such a very big rate. So it's good to keep these things in the back of your mind. So you've seen these data. What I think is interesting and what I wanted to know the opinion of the panel on, but also the opinion of you guys on, is about the endpoint that was chosen, the non-procedure related major bleeding or the clinically relevant non-major bleeding. That is not what we are used to in most trials. It's usually major bleeding and BARC criteria and things like that, but that was not what was chosen here. And if we actually look very critically, then you see that most of the endpoints are actually not the major bleedings, but are the clinically relevant non-major bleedings, and most of those are GI bleedings and hematuria. Those are the most common things, or nosebleeds. Now, this is good to think about that, because the people that are not part of the LAA club, but are part of the non-LAA club, as Martin already mentioned them, how compelling are the data? So this is actually the first question that I wanted to ask to the panel and to you guys. Do you think that the superiority for bleeding in the LAO group in the option trial is strong enough? And my answer A would be no. It should have been better if we had procedural and major bleeding as endpoints and that BARC criteria. Or it should have been better for major bleeding alone. Or yes, it is relevant, but only in patients with a high risk of bleeding. And remember, these patients that we had here were not high-risk patients. They were average, regular patients. They did not have a particularly high risk of bleeding. Or D, non-procedural major bleeding and clinically relevant non-bleeding are compelling enough. This is a very good endpoint. And as Martin said, we should go ahead and do this and do ablation plus appendage closure.
Okay, so if I might ask the showman here, I think we need some physiotherapy after 6 hours of meeting. Yeah. So everybody needs to show his hands, only at one option here. So who's A? Okay, nobody. B? 2? Okay. So who's C? Okay, so everybody's for D. Raise your hands up.
There we go.
Is this really everybody? Okay.
So in the LAA club, and that's where we are here, everybody is in favor.
What do you think about it?
I agree with the group.
Okay, that's interesting, but because I think that there have been some voices obviously about how relevant is this, and if you look at this, I could also imagine that you could say, well, maybe if a patient develops such a bleeding, usually these bleedings are not so severe.
We need
why
to
can't
make
we
this
just
more
wait for
interesting.
that?
They're the two ones who said B, and I think
Please
outside
go
of the
ahead.
LAA club, this would be the majority. So,
Sure.
Get the design of the trial, but I really don't understand why in the first 3 months, bleeding is also double in the group without implant. Because in that group with the implant, they're getting both DOAC and aspirin, which is increasing bleeding. So I don't know why in the first 3 months, it's a double rate of bleeding in the group without implant.
I think that's a fair question. I would say that in the group that has the implant, it's not DOAC plus aspirin. I think that most will either get DOAC
Yes,
or...
it's 90 days DOAC plus aspirin.
Yeah.
but isn't it in the US that it's 45 days
Yeah.
NOAC, and then it switches, and the graph, maybe we can show it up, is 45 days, it's really identical, and then it drops in the LAAC group. So I always thought this slide to be very logic.
The study protocol says it's 90 days DOAC plus aspirin.
Okay, so I'm wrong, yeah, okay.
Yeah, so indeed you see that difference already in the first 3 months, and probably...
If you look there, it's double. It's
Yep.
double in the group that is just
Yep.
receiving anticoagulation versus the group that's receiving anticoagulation plus aspirin.
It separates immediately, true.
It was interesting to see the type of bleeding, the slide that we have shown. I don't know if it's Martin or you. This is very interesting because you can criticize that. I mean, because what kind of GI bleeding, what kind of hematoma? It was really like one episode of epistaxis was counted as a clinically irrelevant bleeding. I mean, it's probably the most critics that you can do to the trial, that you want. Okay, it's non-inferior in terms of stroke, so you have the same protection. You don't have difference in major bleeding, so this is already good results. But when you want to claim superiority, that's the critics, I think, for this trial, that those bleedings are. It depends on how you define. For example, someone that has a lot of small GI bleeding, he will not live with that. He will stop his treatment. So I think that's the point of discussion.
I agree that outside this group, it's dangerous, I think, to get out and now say LAAC is superior. Yeah. I think nobody would subscribe to that, but to have it to patient choice, I always come back to the same, that you can go one side or the other. I think the data are sufficient to argue on that. Jens?
Yeah, but on the other hand, Martin, how to persuade a patient with even something which we called benign epistaxis? That patient considered that it is severe bleeding for him, and try to persuade that patient, you have to take the drug again.
I won't persuade him. I do an LAA, you know.
Yeah. So I am saying
we're all together here, eh? But
yes.
No, this is not just trivial minor bleeding. I mean, you can look at gastrointestinal bleeding. There are more gastrointestinal bleeds in the all anticoagulation group, and also remember the curves for major bleeding numerically. I know it's not statistically significant, but there is numerically more major bleeds, and also I think all will appreciate that having those clinical significant non-major bleeds, they are also precursors of major bleeding. Those are patients that have a bleeding tendency that gets those bleedings. So, and how can you, I mean, the group here was with a Hasbled score of 1.2.
Jens, to answer that makes you understand the outside world, outside this club. I talked to a GI guy who told me, Martin, these GI bleeds are really great. Why are they? Well, that's where we detect the tumors. Yeah. And so we need all these patients. There we do
it's
the
very
coloscopy.
cynical, but this is actually true.
And he meant that seriously.
Yeah.
So
probably all of you have such
yeah?
patients.
So
I have at least one or two of these patients. Yeah.
So
Epistaxis, I agree, but maybe if you add all the bleeding, for example, bruising, what is bruising, one bursitis, so, okay, you collect all the bleedings, but it
in summary,
to overestimate a little bit the impact.
In summary, I would say that if you look at all these small individual things, you might say, yeah, what's that? But if you add them all up,
we have another 9 minutes for the last 5 questions.
Yep.
Sorry.
Okay. Well, let's go ahead and discuss this. Which patients should be eligible for ablation and LAO? Should it be the patients that have a CHA2DS2-VASc score of 1 or more undergoing ablation? So that actually means almost everyone undergoing ablation. Very few, well, there's a group that has no risk factor, but most of them will have one risk factor at least. Or should we only go for patients with a higher CHA2DS2-VASc score, so like 3 or more? To sort of cut the number of patients? Or should we only go for patients that have a high Hasblad score of 3 or more? Or should we only go for patients with major bleeding? Because our healthcare insurance companies and our healthcare policy makers are going to ask us these questions because they will fear the money. What do you think? Martin, as quizmaster.
Yes. So maybe let's modify it a little bit because everybody has also his reimbursement in mind. So when we leave this meeting this weekend and we go home, who will ask and offer LAA closure to his patients with a CHA2DS2-VASc larger than 1? So A? Okay, so sorry. Who will go with B? Maybe superior, okay. 3, 4, 5. Who's going with C? So what we do currently. And the rest is D? Okay, everybody needs to vote, huh? So, okay.
Don't be shy, yeah? Don't be shy.
But
people will say remove 1.
Yeah. Or should it be a combination of these things? Huh?
But that would mean we do the same as we did before. And I think really option gives us a little bit advantage. I would argue in favor of the option with the CHA2DS2-VASc because I think those are also the patients that have a high risk of stroke and they won't take their NOACs for long because they get the bleeding. And the message from option for me is they may do better with the LAAC. But,
actually, that's why I showed this part because in fact half of the group has a CHA2DS2-VASc has a pretty low CHA2DS2-VASc score of 2 or 3, and then the other half really has a higher CHA2DS2-VASc score. So you could argue maybe it's one or the other group, but actually it's pretty. It actually goes for almost all the patients. Now we don't know which patients they actually.
Let's hear the Swiss boys.
Sure. Do you think it's time to recalibrate? Because if you look at the Ablation trial, completely much less stroke, the option, I mean, it's no longer reliable.
Oh, that's a fair point, but that's another question. I mean, if you look at Artesia and also NOAF, if you look at those subclinical stroke rates, they were very, very low, 1%. Even CHA2DS2-VASc scores of 4 or more didn't matter, also very low stroke rates. So the question is indeed whether stroke rates, stroke risk, if you calculate that by using CHA2DS2-VASc, if that's really reliable anymore.
And what's your explanation? Because obviously there's a change over time. Is it the ablation or is it just that we include low-risk patients in our trials?
I think it has
because
nothing to do.
In the same context, you also mentioned that the bleeding rate is in the don't know, with the Cabana trial is at 3 years.
3 major
3%.
Bleeding rate.
However, in all the pivotal trial on DOACs, it was clearly between 2 and 3% per year, major bleeding.
Yep.
So it was quite higher. And you know, in Switzerland, we had this large AF cohort of 4,000 patients, and their major bleeding at 4 years was 10%. So also there, maybe there is a change, I don't know, but what's your interpretation on that change over time?
I think that we are treating relevant of these variants that we have in CHA2DS2-VASc. We are treating many of them, like hypertension and congestive heart failure. There's new drugs. So I think that we are treating these patients much more intensively than we used to do that. So I think overall, the general health in the population, also in the AFib patients, is probably better than in the older trials that we did. So probably we should look at this again and see whether this is really validated in the current day and age. I do think so.
So you think that has impact on Catalyst and Champion in terms of the non-inferiority design? Will there be lack of power, and that will be the argument of the EP community for the next guidelines, that it's not powered?
That could be, because that was the same comment that was made about the option trial, that the power calculation was done based on an event rate of 10% or something like that, with a superiority or inferiority margin of 5%, but the actual event rate was 5. And so this was criticized by people that actually, this was not working in accordance with the trial design. So that could happen, that the same is true for other trials that are designed now, looking at CHA2DS2-VASc score and predicting it based on CHA2DS2-VASc score. That could.
There's another question?
Yeah, sure.
Yes, thank you. I'm not sure how to present this question, but I try. I found the discussion very difficult, actually, around option, because patients for option trial are the same patient that we do not ablate, actually. It's just that those one, we ablate them. So people with a chest VASC or of one or more, they need anticoagulation, and we are wondering if we close their appendage or not, for example. And now we have some kind of proof about what's happening after the ablation, and we might think that it's very advantageous for them to close the appendage in terms of bleeding and everything, but it's the same for people that we do not ablate. So my question is, what is the difference with the general population? Is that they have less AFib because of ablation? Is it that we are making an intervention, so we are wondering to combine a second with the first one? Not exactly, because some of them had 2 interventions at the end of the day. So my question is, what's the difference between option and not option? That's a kind of question.
Well,
you understand what I mean? Because
I understand what you mean.
I'm very disturbed to answer the question, which I found very interesting, because I will try to answer them for a general population, actually.
Okay, so you're...
and just to finish the question,
yeah, okay.
are we transforming these patients in clinical AFib to subclinical AFib? And then what conclusions do we take of this transformation? Do we have all the data today to know if we have to anticoagulate or close appendage in those people?
These are 2 fair points. So what is the option for people that do not undergo an ablation? Sometimes they are less symptomatic, sometimes they are beyond repair, sometimes they're too sick, sometimes they're not sick. So it's hard to extrapolate this population that was symptomatic, had antiarrhythmic drugs before that failed, and they wanted an ablation, and those were the patients that we tried to enter into the trial. So that's a specific population. The other patients that do not get it usually have a low burden, and therefore they don't want to go for an ablation, or they are afraid for an ablation, or sometimes we as physicians decide that an ablation is probably not going to help them, or they are not referred. So they are not all the same patients. I wouldn't say that the patients that you ablate are the same patients that you do not ablate. I think there is a big difference between these patients, also in comorbidity.
I always thought that, I mean, in an ideal world, we would first have the results of Champion AF, and then we would have the results of option, because normally... and I was also very critical when it turned out option recruited much faster and was started much earlier. But in my environment in Hamburg, that's the real world now. I hardly see an AFib patient that wasn't seen by an EP and he tried to ablate it. So it's now, for some reason, more of the real world than, let's say, the pure population that we got. I don't know how it is in Italy or in other...
Just go on, and it'll start working.
Start working, yeah. Okay. Well, I have the perception that you reduce the value of AF ablation. I think there's a big difference between the option yes or option not. I mean, just the patient who were included in option trial. I mean, just this is a typical patient that we ablate. I mean, so this is, I think that the value of AF ablation is there. We have a robust data. I mean, just so I think that's really a big difference between, I mean, just option yes or option no. I mean, so I try just to deliver a message that, if you do AF ablation, I mean, you can reduce, probably the stroke risk, at least in patients with the paroxysmal atrial fibrillation. And therefore, there's really a major advantage, not doing anything. And I would touch even the subclinical or, the so-called asymptomatic AF. I mean, we do ablation even in those patients with the, recurrences asymptomatically, but they have the same stroke risk than symptomatic. So this is something that, it's very debatable, but, everybody has, their own philosophy and approach. But I mean, this is.
We are not talking about silent AF.
Yes.
That's something else. That's device-detected silent AF. We are talking about patients in persistent AF usually that have some shortness of breath, but they don't.
Maybe we can
have a different symptom.
We can cut this discussion short. Is anybody in the EP world aware that there is a study where you stop NOAC after ablation in a 70-year-old patient?
No, I don't think there is.
Yeah? Well, but that's... Okay, and then we will stop NOACs after successful ablation?
If the trial shows that this is safe and feasible, yes. That's the design of the trial.
Okay.
It's not published yet. It finished recruiting, but it still needs... It was indication for ongoing anticoagulation, so 2 or more.
Okay, so we'll see that, and then we'll have the answer. That's easy. You have more questions?
I have many more questions, but I see that we are running over time, so I don't want to disturb you, and I have to catch my plane also.
Okay, thank you.